and ideally that we should have done this CME. However, we are still in time, and we thank God for this opportunity. Thank you so much for allowing us. So it was a month of awareness, and the Ministry of Health put measure and the team to try and commemorate this day and work hard to see that we spread the awareness message about sepsis. And the theme, it was basically 5 life-saving actions to prevent sepsis. Act fast, prevent infections, get vaccinated, use antibiotics wisely, and demand safe care. And we had some information which was running on social media. I don't know if some of you got it, but it was mainly for the community. However, as health workers, we always need a revamp of knowledge. And tonight we are going to listen about the in-depth of sepsis. We shall have a nurse called Sister Lichiko Emily, who will be talking about nursing care. And then we shall have an obstetrician and a pediatrician, myself, and a microbiologist. The reason we brought this in a way to have a multidisciplinary action, because we know most of you work on so many people. You find one who works in maternity, the medical officers deal with mothers, they deal with children, and the nurses as well. So let's listen in and take the best out of it. We shall be present to answer your questions. Henceforth, we hope to have improvement in management of patients with sepsis. Back to you, Chair. Thank you.
Thank you, Dr. Mirembe. Dr. Tatumwa, I think you can hand over us to the moderator so that we can begin the session.
So I have just made the introduction, so we can start having the presentations.
Dr. Mirembe, can you share your screen and we start?
Okay. We expected that you have the slides. I didn't expect to be sharing the slides myself.
Oh, Dr. Tatumwa, you have the slide. You can share on our behalf.
Yes, you shared the slides, and ideally.
Yeah, Dr. Tatumwa has it. Hope he's going to share.
And the moderator will also give us the lineup. But all the presenters are already on. I see Emily's on, Dr. Charles is on, and yourself, I am myself.
I hope the slides are visible, and I hope the lineup of the presenters will follow, having Dr. Irumba, then Dr. Mirembe, Sister Emily, and Dr. Mutumba. Hope that's the order that we shall follow.
That's okay.
Yes, good evening, everyone.
At this point, we can have Dr. Irumba.
Yeah, good evening, everyone. Am I audible?
Sure, you're audible.
Thank you so much. My name is Charles Irumba. I'm an obstetrician. I work at Women's Hospital, and Mulago, I belong to AOGU, UMA, and all those affiliations. And also, I belong to the NASMEC Infectious Diseases Committee. And we have been doing some work on Marano sepsis. I'm privileged to be here. Thank you, the organizers of the Health Forum, and everyone has put a hand. And go to the next slide. Next. Can I go to the next slide, please? Yes. So, as a definition, sepsis is really a clinical syndrome resulting from dysregulation of the host's immune response. And in a way, when the body is overwhelmed, the immune system targets its organs. So in that line, you can end up going with septic shock, which is a more severe form of sepsis, caused by hypotension, and most of the time it is refractory. Other treatments, signs of reducing perfusion with a lower MAP less than 60 and hypoxia. And the mortality rates vary from anywhere 10% to 40%. This is according to WHO and some little data in Uganda. So we have been used to it being called sepsis, but in 2017, the nomenclature was changed and it was named maternal sepsis, and it was defined by WHO as life-threatening condition characterized by organ dysfunction from infection during pregnancy, childbirth, post-abortion, and postpartum period. So this is when we spectrum maternal sepsis, and therefore we should be vigilant as we take care of those mothers, monitor them, their babies. And like I said, when the body's defense reacts against infections, it causes harm to its organs. That results in sepsis and can affect all populations. Therefore, everyone is at risk, regardless of whether they're giving birth or not, including children. And specifically in pregnant women and those in preterium, they are more susceptible to a rapid deterioration following an infection. This is because of the changes in the immune system, and the other conventional adaptations of non-pregnancy, which may make it difficult to suspect maternal sepsis and therefore delay intervention. Therefore, we should have a high index of suspicion if you have saved these mothers. The WHO reports it to be about 4.4%, the highest burden being with us in low and middle income countries, about 7%, and in Uganda, some studies have put it up to almost 31%. And the MBDSI report of 23-2024 financial year, it caused 9% of Next slide, please. So we have some risk factors which can be social, medical, related to childbirth, but also in the facilities. As usual, poverty is a problem. It affects healthy behavior, having very distant health facilities, extremes of age, low education level, and safe abortions, reduced autonomy of women, and in the medical factors, the woman is a prime para, also not experienced. They've had a prior miscarriage, they're anemic. If they have untreated chronic conditions like HIV, diabetes, hypertension, cardiac disease, obesity, malaria, malnutrition, and other infections. But also during childbirth, if you have induction of labor, if you have pre-labor rupture of membranes, if you have long labor, if you're not monitoring labor very well, you risk those patients having sepsis. If we do multiple vaginal exams, inappropriate cesarean sections without prophylactic antibiotics, multiple births, deliveries, those episiotomies and identical conditions can actually cause these problems. But also we have interfacility conditions like hygiene, sanitation. I not know about the WASH project. Also need to be careful. The cleaners have a role to play, therefore they must be trained. Next slide. Next slide, please. So, maternal sepsis is a medical emergency warranting rapid or quick recognition, and interventions initiated within an hour can actually save many lives. And like we said, in pregnancy and preterium, there's rapid progression. Therefore, we have to be very alert. And the recognition of the signs and symptoms is crucial to enable prompt treatment. And like we said, it can be difficult in pregnancy because the signs and symptoms are masked by the changes in pregnancy. Therefore, we must have high index of suspicion. And sepsis should be suspected if a mother has a confirmed or suspected infection plus any sign of organ dysfunction, and therefore we have to be able to initiate treatment. Next slide. So optimal management requires a multidisciplinary team, and the most senior cadre in that health facility should be called upon to take over lead of management, and all this in a bid to prevent organ dysfunction. Therefore, we should take a detailed history, clinical examination, and when you do this, you have over 80% of the diagnosis and supported by laboratories, which are here. And abnormal vital signs can herald impaired organ dysfunction and therefore need urgent intervention. And these signs can be identified by taking the vital signs, the respiratory rate, the heart rate, blood pressure, urine output, and the mental state exam, and charted in the MU's chart, as we shall see. Any of those should raise clinical suspicion of sepsis. Next slide, please. So the clinical signs and symptoms are signs of infection, and they cross-cut against the virus differentials, and therefore the clinician should be alert. But like we said, the vital signs, if you have a high respiratory rate of over 25 breaths, should be concerned. Saturation going below 92%, other tachycardia over 130, systolic blood pressure less than 90, patient has not passed urine in over 18 hours. That points to kidney injury. If there is a change in the patient's mental state, if there is serum lactate, which is greater than 2 millimole per liter, a non-blanching rash or molted ashen skin, this is more maybe light-skinned people. Low abdominal pain, some bloated uterus, foul smelling, vaginal discharge or lochia or pus, and laboratory examination of the discharge revealing the causative bacteria, and therefore should be very, very alert. First of all, hypothermia has a strong association with adverse outcomes. Therefore, patients should be warm, but fever per se, not evidence for sepsis, because we know in the early postpartum period, patients actually have high blood pressure. Therefore, in the management, the standard doses, we said, is a medical emergency. Our ABCs should be sorted. The airway should be clear, they should be breathing well, and it should be circulating well. So we need to restore. And patients with septic shock can have issues with their volume and the blood pressure. As we shall see the MU's chart, when you make those observations, you must record them serially and repetitively over a given time interval for them to be able to make sense, and then for you to be able to know when to escalate and to de-escalate, and should inform the most senior of all the clinicians in your unit, medical officer, obstetrician, anesthetist, and the rest. Do not wait for microbiology results to initiate empirical treatment. You can offer broad spectrum antibiotics in and out of diagnosis, depending on what you have in your facility. And if you're lucky and have an antibiogram, please follow that. And you can readjust this anytime when you get the culture sensitivity results. Next slide. So care of these patients is really effective if you use care bundles like we have seen in PPH, it works. So generally those care bundles are evidence-based components or procedures. When performed together and reliably, improve patient outcomes, and completion of each element of the bundle ensures that we achieve the desired outcome. And particularly for sepsis, we have the first M bundle, as we shall see, and the aim is really to maintain perfusion of vital organs while identifying any life-threatening conditions to save these patients. And for patients with sepsis, treatment is crucial, like we said, and the institution of maternal sepsis should be prompt immediate review by a senior. Next slide. So fluids is the first part of the first M. This is resuscitation, restore organ function, and we need a more balanced crystalloid like Ringer's lactate or normal saline, which we have, and at a rate of 30 mils per kilogram over 3 hours, and can be reduced to 20 mils per kilogram, which increases risk for pulmonary edema, pregnancy, and also those that have preeclampsia, hypertension, diabetes. And it's recommended that you give in terms of boluses of 500 mils of crystalloid and reassess the hemodynamic status of the patient to determine whether you should add or sustain that or stop. Next slide. Next slide, please. And you can do passive leg raise. If you remember this, you put the head down and raise the leg so that you transfer blood from the periphery to the more vital organs, knees, the brain, and the like. And this has been shown together with the fluids, it can raise the mean arterial pressure. Remember, we said that it's associated with decreased perfusion. And under the guidance of the anesthetist, you can give norepinephrine. It's the most recommended vasopressor for use in malarial sepsis, and it can help to raise and sustain the MAP as you look for definitive treatment, for example, ICU or HDU. And we should be really careful as we give this to these patients. And the only way to be careful is to do continuous monitoring. Next slide. The second part of the first aim is antibiotics. And as we said, antibiotics are the cornerstone of management of sepsis because usually think is an infectious agent. Therefore, initiate critical broad spectrum antibiotics within an hour of recognition. And before you give antibiotics, take off samples of blood culture and sensitivity. And if for any reason you're unable to do blood culture and sensitivity, please don't hesitate to give antibiotics. And later on, when you get your results of culture sensitivity, you can narrow down the antibiotic regimen. But in all this, we should make sure that we have antibiotic stewardship with us and we are not misusing antibiotics. We are not using them irrationally. Next slide. So when you look at our essential maternal clinical care guidelines, for non-severe sepsis, first line is ampicillin and metronidazole, or ceftriaxone, or amoxiclav. And if you think the patient might turn out to have severe sepsis, you can give a one-off dose of gentamicin of 5 milligrams per kilogram. But if you're allergic to penicillin and cephalosporin, you can give clindamycin or gentamicin. And for extended spectrum lactamase organisms, you can use meropenem. Next slide. Next slide, please. Yes, now for severe sepsis, again, we can use ampicillin gentamicin, metronidazole, as we await the sensitivity profile. But if you have your antibiogram for your hospital, you can use your most appropriate first line antibiotics. And you can, or if you don't have those, you can give piperas and tazobactam, not so common, but maybe in urban centers, pacificamycin. And the second line, if there is non-severe penicillin allergy and ESB organization, you can consider meropenem, like we said. Though there's emerging resistance to these carbapenems, so we also have to be very keen. But also, we can add to the first line and second line therapy if there is a group Streptococcus infection suspected, you can add clindamycin on the first line and second line. And if you have necessarily resistant Staph aureus, you can use vancomycin. The third line, definitely, if it's severe penicillin allergy, is vancomycin and gentamicin, plus minus metronidazole. And I think most of these are in our medicine hospitals. Next slide. Next slide, please. So these ones probably the microbiologists will tell us, but I will try to talk through them. And this is information we can find in terms of the spectrum, what is covered, what they don't cover, and how to mix them. Can we go to the next slide? There's a bit I'll talk about prevention. Prevention is within our reach, and we can use low-cost measures. For example, hand washing. We know the WHO moments of hand washing when you reach the ward, before you touch the patient, before you do a procedure, when you have a spill. Therefore, you should be able to do appropriate hand washing with appropriate running water and soap. Appropriate decontamination, sterilization of equipment, linen, our theaters and wards periodically. This will help reduce the burden of the infectious organisms. Some have gone ahead even to swamp clinicians and their courts, see what they have and how to manage it. We also have appropriate waste management. We have the new IPC guidelines, and we should be able to appropriately use them. For us in the maternal and child health, antenatal is critical, natal care. Mothers should attend antenatal care because we give them supplements, iron, we give them information so that they are able to take care of themselves and also to prophylactic or preventive drugs like for malaria, other conditions. Malaria was just symptomatic in pregnancy. But also regular drills are critical in management of these conditions, together with the continuous and appropriate consultation and use of protocols. Use of protocols during care of patients has been found to reduce sepsis and death. Thanks for listening to me. Over to you, Dr. Miriam. Thank you.
Thank you so much, Doctor, for that presentation. Right now, I think we can move on to the next presenter. I request Solomon. Solomon, kindly behave. Avoid touching your screen. You need to keep everyone safe. Don't spoil our screen, Solomon. Okay, we can have another presenter to pick it from there. Dr. Mutumba, do you know who is coming next?
Myself, pediatrics.
Dr. Mirembe.
Okay, Sister Mirembe. Thank you.
Thank you so much. I'll reintroduce myself for those who have just logged in. I'm Immaculate Mirembe is my name, and I'm a pediatrician. I'll be adding on to what Dr. Irumba has talked about. He has basically focused on maternal sepsis, and I'll talk about pediatrics. Previous slide, please. Previous slide. I don't know if that's where my slide. Okay, next slide. Next slide. So in a nutshell, maybe the structure of this presentation is I'm not going to focus on investigation, but I'll hit on them. And Dr. Mutumba will be highlighting for us the investigations that are available, but I'll hint on them in my presentation. So pediatric sepsis has a very high incidence of 48 per 100,000 children per year. And it's the largest cause of childhood mortality worldwide. Nearly 20 million cases in 2020, according to WHO, occurred in children 5 years of age. And in developing countries like ours, it has been documented 50% of all deaths in children younger than 5 years is because of sepsis. And maybe to highlight once again that why is sepsis very peculiar? Oftentimes it starts in a subtle and it can progress rapidly, and a child can die sick in the morning, by evening is gone. So as health workers, we need to be very keen about diagnosing sepsis the right way. The other challenge with sepsis, we are over treating it. Every child is eating antibiotics, even when it's not necessary. So it's very good as health workers to have the proper clinical signs and symptoms that guide us to know that indeed right now I'm treating sepsis. Because of that overuse, we have created a lot of antibiotic resistance, and most of our drugs now are not working. So that would be my opening statement, because it's very important. There are so many children you see working with cannulas when they just have a cough and they are being told they have infection. So according to age, you can classify sepsis, maybe a newborn. Their organisms have a specific age predilection. When it comes to newborn, we can classify between community and hospital-acquired. We can also classify as early onset, those who get sepsis below 72 hours, or late onset above that up to 3 months. So each age group has a category of organisms that they acquire. Then local epidemiology means that according to your region, there are organisms that may be very friendly. So the season also matters. The organisms, we know that flu-like illnesses, for example, virus sepsis, we see it a lot in the cold season. The site as well, and the presence of immunodeficiency. Children who are immunocompromised, sickle cell, diabetes, neonates, chronic illnesses, those who have malignancies, they are prone to sepsis. So when we talk about early onset in neonates, we are talking about vertical transmission from the birth canal to the uterus, or a hematogenous spread from the mother. And the most notorious organism is group B. Countries that have very good systems, they screen for group B strep for every mother who is positive, because they know it's a very high risk factor. Mothers who have had chorioamnionitis, preterm births, the other common organisms, E. coli, and others. For late onset sepsis acquired in the community, or even in our neonatal units, we see organisms like coagulate negative staph aureus. It's basically health worker induced to the patient. And then we have torches. We have things like syphilis, toxo. These are now congenital infections coming from the mother to the baby. All these, we need to have a high index of suspicion whenever baby presents with signs of sepsis. So with gram-negative sepsis, which is very notorious and very resistant to most of our drugs, Klebsiella is common in our environment, and we always need to have a high index of suspicion. There are so many cultures that have shown Klebsiella and resistance to drugs. Let's move to the next slide. We can also have fungal sepsis or virus sepsis. The other organisms that can lead us to sepsis, malaria, and it complicates with sepsis. We have in the older children, in the older age, we have strep pneumonia, it's very common with respiratory tract infection. We have mycoplasma, and then Neisseria meningitidis causing us meningitis. And then we have viruses. You had the epidemic of COVID-19. It didn't spare children. We've been having monkeypox. We've been having some regions having Ebola. And RSV, very common in babies around 3 months. They come with severe respiratory distress, more of a bronchiolitis picture. Next slide. Now, how do we diagnose pediatric sepsis, newborn sepsis? I want to highlight that there is no single diagnostic test or even a clinical sensitive rule to diagnose sepsis. The best approach is having a high level of clinical suspicion. When a patient enters your consultation room or a baby is on your ward for whatever reason, probably they came in with a cough, do a daily assessment. It all starts with a clinical history. How do we take our history? Your history should point, we should have pointers towards as risk factors for sepsis. For example, in the newborn, the history around the delivery. What is the gestational age? Was the mother ill? Did she drain like or before time? So that one gives you a hint. Okay, and then there's some classical signs which are sensed, like vomiting, for example, in babies. When a baby comes in vomiting, in a neonate, vomiting, abdominal distension, that most likely causes sepsis, coupled with failure to breastfeed. The same thing with older children, although for them they can spike a high temperature above 38. Unlike neonates, sometimes they have a hypothermia less than 6.5. The other thing is the tachypnea. The respiratory rate may go high. So you have to have a habit of taking vitals. What is the respiratory rate for age? Remember, in children, you have to correlate with the age. A neonate can respire at 40, 60 breaths per minute and it's normal, whereas it's an older child at 1 year, 2 years, that is quite high. A tachycardia, any baby who has more than 120, an infant with a heart rate more than 120, 130. If it's a neonate, between anything above 160 is high. For babies, anything less than 100 is a bradycardia. Remember to always incorporate the age while interpreting these results. So we should be having knowledge of normal vital signs for each age group. Children who are older, infants up to 6 months, they are almost still in the same range, but they range up to around 150. And then above 1 year, you start seeing the heart rate dropping maximum to about 120. Above 5 years, the child should not be having a heart rate above 120. That is a tachycardia. So learning to interpret your signs and taking your vitals. The other thing which is very peculiar is confusion, CNS manifestation. A child comes in with seizures, they've been having convulsions, combined with fevers, failure to feed. Then you have to suspect a probable meningitis. Septic shock, I want to highlight it very much because as you're assessing this baby, they are on your ward for whatever reason they came, be it malaria, be it a respiratory tract infection. On a daily basis, you should be looking out for signs of shock. And shock is diagnosed by basically doing vitals. I know in pediatrics, we are supposed to be doing blood pressure, but we are not able to. But you touch the patient's extremities, they can guide you a lot. Touch the extremities, are they cold or warm? Okay. Peripheries that are cold are more significant of shock. However, you can also have warm shock. And if the peripheries are warm, but you have a very high heart rate of about 180, it's very significant of septic shock. And a capillary fill time, you press the nail bed for about 3 seconds. And then when it recoils, it takes some time to return, more than 3 seconds. Let's go back to the previous slide. That's a sign of shock. The infant may become pale, cyanotic. They get a mottled skin. They get like round things on the body, especially those who are small babies and they're light skinned. You see round things on their body. They may get cyanosis. The extremities become. That's a sign of septic shock. And this is an emergency. You need to act urgently. Next slide, please. So that slide is just showing us all the systems. When you have sepsis, any system can be affected. Some of them I've already talked about. For example, jaundice in neonates, the respiratory distress, feeding intolerance, vomiting, diarrhea. Like you can see, there is no specific pointer that this is sepsis, but it's a collection of signs and symptoms combined with your history. Then you make a diagnosis of sepsis. Next slide. Whenever you have sepsis, try and find the focus. So the previous slide actually guides. There's respiratory, then you know the focus is most likely respiratory. There is CNS manifestations, then your focus is most likely CNS. If you have the abdominal, then you think along the GI. The initial focus of treatment is stabilization. The ABCs, airway. How is the airway pattern? Give the patient oxygen. Give the patient oxygen 100%. If they have respiratory distress, put them on STIP. The breathing, that's the stabilization we are talking about. Stabilize the breathing, put in a secure left lateral position, elevate the head of the bed. Correction of metabolic, circulatory, and respiratory abnormalities. Aggressive fluid resuscitation. Now, if a patient has shock and you have diagnosed shock, in children, we do not give routine IV fluids. In adults, when you come in hospital with a fever, immediately they connect a normal saline bottle. In children, you have to have evidence of septic shock or some dehydration for you to start IV, severe dehydration for you to start IV fluid. So we should be having knowledge on how to assess for shock or some dehydration. Ventilate the baby for those who have failed to sustain breathing. And the HB, you want the HB in severe sepsis to be above 7. So you'll find yourself transfusing at a lower threshold. At about 7, you may need to transfuse in shock. And the most important thing when you're managing sepsis, make sure the organs are safe, because sepsis causes multi-organ failure. Make sure you monitor urine output. If a patient is not making urine, the sepsis can also cause renal injury. So you have to be very observant. Next slide. Next slide. So what are the do's? Once you diagnose sepsis, the standard of practice should be take off a blood culture. So we have been informed and reliably informed. Ministry of Health has supplied blood culture bottles to all regional referrals. Please make use of those blood culture bottles. They should not delay. When you take off a blood culture before you start treatment, you're not going to be stuck in the middle of treatment and you're like, patient has not improved, what am I going to do? You have evidence that this is the bag, you stop whatever you are giving and you switch on to what the culture has told you. The mistake we do, the patient first deteriorates and then we think, oh, let me now start taking off a culture, and the organisms have been partially killed and they cannot be identified. However, the technique is very important. Invite the lab team to help you if you don't know how to take off. In children, you need about 2 meals on. CSF, for those who have CNS manifestation, I request the people in laboratory to help us to improve our CSF sampling techniques, rather sampling investigations. Because sometimes you take it off and they're not giving you a full analysis. Urine cultures, the focus, if there is pus, remove it and swab it. Do a CBC. Dr. Mtumba will comment on it, but in children, it can guide you whether you have a bacterial or a virus sepsis. The urine neutrophils will go high, above normal. Your lymphocytes will go high in virus. Antibiotic agents should be given as soon as possible according to the most likely pathogens. Do not delay to start antibiotics because we cannot investigations. Now, for newborns, the first lines is ampicillin, and the dose has been increased to 100 milligrams per kg to improve sensitivity. Gentamicin for 5 days. And our second line is cefotaxime amikacin for babies who are not improving on your first line. Next slide. Still, if you take these off and you have a culture, it really comes beautiful. Afterwards, patient is not improving. 5 days, you now have a culture result and you switch. A third generation cephalosporin in older children, ceftriaxone plus a gentamicin in combination because they complement each other and they work better. Patients who have fever and neutropenia most likely have gram-negative sepsis, and amikacin it works well. Now, like we said, always identifies it virus sepsis. If it's most likely virus sepsis, the child has vesicle, then you're dealing with virus like chicken pox. Don't just give antibiotics. You have to add a cyclover. And it's very important to complete the duration. Our dear interns on the call and junior doctors, you're not completing treatment and you're causing resistance. A patient receives 3 days, gets improvement, and you discharge them of treatment and you give them a syrup. There are conditions where you don't need a syrup and you need to complete treatment. For example, a newborn sepsis, a baby should get their 5 days of amphigen even if they have improved. Next, give the anti-malarials, give the antifungals accordingly. Fluconazole is available on the market. Next slide, please. I think this should be the last slide. So I want to talk in detail about shock. Now, when we learn to diagnose shock, we should also learn to manage it. There's a lot of panic. But with shock, once it is diagnosed, it's about now classifying it. If it is septic shock, rapid restoration of circulation is important. Like I said, oxygen delivery via aggressive volume replacement therapy is also important. It is the single most important intervention in the acute management of septic shock. So we use crystalloid, but remember in children, you want to know whether they are malnourished or not. This is very important. So you have made your diagnosis of shock. In malnourished children, you give them 10 mils per kg. You can repeat this bolus, but that 10 mils per kg should be given for overnight. Because for them, their heart is weak and it can easily go into heart failure. For older children, the crystalloids I'm talking about, that is normal saline or Ringer's lactate, 20 mils per kilo. For a child who is not malnourished, you give 2 boluses. You can go up to 3 boluses. But the latest recommendation, according to the EPALS, that's the European Pediatric Advanced Life Support, it is recommended 40 mils maximum. You can give 20 mils, then you add another 10, then you give another 10. And in septic shock, it is advisable to transfuse. Transfusion 20 mils per kg is indicated. If you have given your bolus and you're sure it is septic shock, because it's a volume issue, you have peripheral vasodilatation, you can't give blood. Oxygen is a must. Make sure your HB is above 7 and monitor your urine output. Now, while you're giving these fluids, always monitor the cardiac, because there are so many babies who receive fluids and they end up going into heart failure. So as you're giving your fluids, you're assessing your liver for tenderness, you're assessing the chest for any crepitations. That's the sign of heart failure. And if that happens, you may need to switch to vasopressors. I have written there. Support, if there's no improvement, you need to switch all the dopamine. You don't want to use dopamine because of renal shock. This should be given via an infusion. And you don't need to cram, just know the drug, get the protocols, get the dosage on how to mix. Consult the anesthetic office or the anesthesiologist if you have one to help you with that. Next slide. Should be finishing. Next slide, please. Yeah, this is the last slide. So how do you prevent sepsis? I think we are all very familiar with the best practice, good hygiene. Practice good hygiene. And the most important is frequent hand washing. Frequent hand washing. A study was done in Barara in 2023. Only 68% of caregivers, they were just assessing adherence to hand washing. Only 68% of caregivers, health workers adhered to hand washing. So let's do hand washing. Our hands transmit sepsis from this baby to the other. You move out of the ward, you go elsewhere, you come back and just touch patients. Let's use those alcohol-based sanitizers. Proper disposal of waste. I think they have invested a lot in IPC practices and training health workers. But remember, it's for you and also the patient. Care for wounds, any cuts and wounds. Clean vaccination. Let's promote immunization. I think the numbers have gone down. Sepsis used to kill more, but they're going down because of vaccination. So let's promote it. Maintain a healthy diet in children, breastfeeding, neonates. Let's promote breastfeeding. Do not advise mothers to buy that tin of milk when it's not necessary. And promote safe practices. Avoid unclean water, unsanitary toilets, unsafe food preparation. Let's continue. I should be done. Do I have? Yes, I think this one is the last for newborn. Basically, those in maternal, clean bath kits, timely delivery for those who have risk factor, clean surfaces. Let's have our units clean, and don't throw around antibiotics. If the baby has no, if the child is not having signs of sepsis, there is no role of an antibiotic. The CBC is clearly viral. is having a flu, why are you giving ceftriaxone to that child? Children with chronic conditions, remember to give them prophylaxis. Those who have malignancies, those who have catheters, indwelling catheter, sickle cell anemia. Yes, thank you. Back to you.
Thank you, Dr. Immaculate. We can have the next presenter. Dr. Mutubadjuno, who is presenting internal medicine.
Yeah, no, internal medicine.
We're not having internal medicine, so we move to Sister Emily.
Yeah, to nursing care.
Okay, we can have Sister to present.
Dr. Tatum, I don't know what is happening with the link. Our sister had posted that he has initially was on, Dr. P. Initially she was on, but she posted that the link had refused to allow her in again. And another colleague also wanted to join under the same problem. I don't know whether.
Is she on call?
Yes, she was on call.
Yes.
She's posting here that she has failed to join in again.
Sister Amy, could you unmute now?
She's back. She's back.
Yeah. Good evening. I'm now back.
Yeah,
thank you, moderator, and members who are present. Can you hear me? Hello?
You're audible.
Hello? Okay. Good evening, members. My name is Likicho Emily Opu. I'm a nursing officer. I work with Mulago Specialized Women and Neonatal Hospital, and I'm the current vice president of the National Midwives Association of Uganda. I'm going. This is not. I'm on someone's slide. Okay, thank you. So we're going to talk about the nursing care. Then we have the nursing problem priorities. The following are nursing priorities for patients with sepsis. It is first to early recognition and diagnosis, as sepsis is a medical emergency. Then 2, the fluid resuscitation. And 3, administering antibiotic therapy. So our first step is prevention of sepsis in nursing. What do we mean? The first is strict infection prevention control. There is washing of hands. This can be washing before and after the procedures, like environment cleanliness, where we are, especially like in the labor wards, they must be clean. And then using aseptic techniques here, well, like when we are handling mothers, you are not supposed to do multiple VEs. You should use aseptic procedures when you are like catheterizing these mothers. And then also wound care. We should also know the techniques of wound care, and then antibiotic stewardship. Then the second one is early recognition and intervention. We should know the early warning scores, then the rapid alarm rising, then patient monitoring, and family education, because we are the first in contact with these clients. So it's very important for us to know the alarms, the red flags. The next slide. The next slide, please. Nursing. We use the nursing process. What do we mean by the nursing process? Nursing process is a systematic patient-centered approach to care, and it involves nursing assessment. This nursing assessment should be subjective and objective. What do we mean? These mothers or any client who comes to you, you need to take thorough history of this client, and they may tell you they have pain. They may tell you they have difficulties in breathing. They may tell you burning with urination, frequent cough, greenish mucus, disorientation or anxiety where there's mental confusion. They may talk of fatigue. They may speak of skin clammy, sweaty, and they may report to you chills. But then, when you are handling these clients, there is also the objective data, which a nurse must understand. There is when you do that, you find there's increased or decreased temperature of 38.5 Celsius or 36, below 36. Then you will see the respiratory distress. The rate will be over 20 beats per minute. Then when you check the urine, there will be decreased urine output. Then there is low blood pressure. Then the heart rate is greater than 100 beats per minute. We can move to the next slide. So we have also the nursing diagnosis. The nursing diagnosis is the first step of care of nursing, during which the nurse formulates to a specific to address the challenges associated with sepsis based on the clinical judgment of the nurse. So we normally use what we call NANDA. In nursing, NANDA is it helps it helps the nurse develop a nursing care plan to meet the patient's short-term and long-term goals. So in this, there's nursing diagnosis, the common diagnosis, because nurses are allowed to generate a care plan based on their clinical judgment, and this NANDA is approved. So according to NANDA, a nurse's diagnosis is a clinical judgment about the human response to health or life. So in this case, this NANDA is accepted. So a nurse, to get that this client has this type of condition, you should use the NANDA. So in this case of sepsis, there's decreased cardiac output, hypothermia, risk for fluid volume, risk for infection. For example, there's one NANDA here, hypothermia related to sepsis, secondary to third-degree burns, as evidenced by 38.5 Celsius, constantly sweating, skin, rapid heart rate, and low blood pressure. So before a doctor assesses this client, the nurse has to have her own nursing diagnosis, which can guide her care. We can move to the next. So we also have nursing goals. In this sepsis, there are those short-term and long-term. So in the short term, the immediate You immediately stabilize through fluid resuscitation. Then there's antibiotic administration. When these drugs are prescribed, nurses are supposed to administer these drugs. There's oxygenation, then there's hemodynamic support, then infection control, continuous monitoring. Then in long term, you promote early mobility, you support long-term physical recovery, then provide psychological support, then educate for relapse of prevention and address residual pain. The next. So in this, we have nursing interventions. Nursing interventions, it will be according to your assessment and your diagnosis. So there is the first nursing intervention or action is initiating infection control and prevention. We know that clients with sepsis are at increased risk for infection due to compromised immune system and presence of pathogenic microorganisms. The system is inflammatory response can also do damage to the body's tissue, resulting in impaired host defense and further increasing the risk of infection. So it's important for the nurse to initiate infection control. Then we have prevent shock. We know that these clients normally, because of loss of then there's enhancing gas exchange and breathing. And then there is managing fluid resuscitation and fluid balance, managing hypothermia and fever, obtaining samples for culture, initiating health teachings and patient education. There's assessing and monitoring for potential complications and administering medications and pharmaceutical support. The next. So in all this care, we have nursing evaluation, because after doing your assessment, your intervention, you have to evaluate done. Now in this, it determines the effectiveness of nursing interventions and determines if the expected outcome was met within the set time. It may not be, of course, when a client comes to you, like with high fever, you expect by the time you do the intervention, the fever should have gone down by a certain time. So for example, risk for infection related immune system as evidenced by expectation is maybe within the form of the patient, the temperature should have normalized. So you just, or the end client. Thank you.
Mr.
Thank
Emily, are you here or you're off?
Thank you, sister. I was waiting for the moderator to give me permission. Am I allowed to continue,
Please,
Doctor?
you are allowed to continue. We're here now.
Oh, yeah, thank you very much. The previous presenters. My role here is to talk about the role of these laboratory tests in the management of sepsis. I would like to make this note that laboratory results are interpreted in the context of the patient's clinical presentation, and this is the reason why it is very important for clinicians to write on lab request forms clinical notes that resonates with the diagnosis, or at least write their impression so that when a result that suggests sepsis is found in the lab, then communication can be made as quickly as possible. But if they do not leave that area of the lab request form where they have to write their history or impression blank, it also becomes not very easy for the lab to communicate in time. Now, laboratory here has very important roles. The first one, laboratory can detect sepsis early, actually before clinical presentations become overt. Laboratory can monitor organ dysfunction in time, such that support therapy is instituted before the dysfunction becomes irreversible. Laboratory can guide therapy, both targeted therapy, but also laboratory can provide data that form the basis of effective empirical therapy, where we do not have time to wait for culture and sensitivity. Fortunately, all the divisions of the laboratory are important in the management of sepsis. Lactate here. Lactate, the results can be got within an hour. And elevated lactate of more than 2 millimoles per liter index suggests poor tissue hypoperfusion. And if it is more than 4 millimoles per liter, this is an indication that suggests severe sepsis or even septic shock, meaning that critical intervention is needed. And lactate can, this one can happen within 6 to 12 hours of the beginning of of onset of sepsis, which is actually quite fast for us to detect. And that result can be available within 1 hour. Then complete blood count has about 3 important patterns. One, reflecting a bacterial infection, a viral infection, and even in the context of a patient presentation, indicating overwhelming sepsis. The bacterial infection signature on a complete blood count will include increase in the number of white blood cell count of more than 12,000 cells per microliter, which means the immune system is responding, or leukopenia, when the white blood cell count is less than normal, less than 4,000 microliter per liter, and an increase in the number of neutrophils, more than 60%, of which the majority can be immature, what we call a left shift, and this is a signature for a bacterial infection. For viral infection, usually the white blood cell count is low or normal. There is a predominance of lymphocytes, and there is no significant left shift, and this can help us to suggest a viral infection as the cause of sepsis and save the patients from unnecessary antibiotic therapy. Then there's a signature of a complete blood count that suggests overwhelming sepsis. Leukopenia, less than 4,000 cells, which means that the immune system now is overwhelmed. Thrombocytopenia, what platelet count less than 100,000, which means that this patient we suggest in the context of the clinical presentation that they may be in severe sepsis or septic shock. Next slide. Yeah, then there is C-reactive protein, quite important, because this one can raise within 6 to 12 hours during onset of sepsis. Previous page, previous slide. Previous slide, I'm talking about C-reactive protein. Yes, there. Yeah, now higher levels, more than normal, indicate severe inflammation, but very high levels, more than 100 milligrams per liter, suggests a bacteria infection. This is important. C-reactive protein is important in monitoring treatment response, whereby if the levels are rising, there is no response to treatment. If the levels are falling, there is response to treatment. Then the other marker of inflammation is procalcitonin, which is ultra-precise bacterial infection detection parameter. It rises specifically for viral infections, bacterial infections, not viral. And usually a finding of more than 0.5 nanograms per mil is indicative of a bacterial infection, and more than 2 nanograms per mil is indicating of severe sepsis and septic shock. And this all here, it is a very good guide to start antibiotic treatment immediately without wasting time. And it gives us stewardship precision, whereby antibiotics are necessary now because it is a viral infection. Then the renal function tests, very important. You know that in sepsis, usually the first organ to get injured is the kidney. And it is important to monitor the baseline on admission and then serial monitoring to find out whether the kidney is dysfunctioning so that interventions are done early enough. If the problem is hypovolemia, resuscitation is done. And if the patient is on drugs that are nephrotoxic, they can be renal adjusted, or if there are alternatives, change to another drug that is not toxic to the kidney. Creatinine, the most important parameter here is the creatinine level that will go high. Next slide. Next slide, please. Yes, the liver function test. The most still here we need the baseline on admission, and also followed by the serial to monitor renal dysfunction. ALT and AST findings of more than 1,000 units, international units per liter, will indicate injury to the hepatocytes, whereas elevated bilirubin and ALP, that one indicates a cholestatic pattern. And then increase the INR, or prothrombin time of more than 1.5 is indicative of a dysfunction in the synthetic ability of the liver. Next slide. Yeah, blood culture. Blood culture. Next slide. Next slide, moderator. Yes, blood culture. Blood culture is the gold standard in the diagnosis of sepsis, especially if the cause is bacterial infection or fungal, and it provides the definitive pathogen identification that is causing bacteremia or that is that is at the source of infection being seeded into blood. it allows us to investigate both deep-seated infections, e.g. endocarditis, especially. So how should these blood cultures be taken? Usually, culture should be taken off before antibiotics are given, because antibiotics will affect the rate of cultivation. What affects the positivity rate of blood cultures? The techniques for correction is very important. Usually, we need adequate volumes, and then the sets. For adults, we need 40 ml per episode, where two sets of 20 ml. We need two sets. Each set, we need 10 mils per bottle, and a minimum of two sets per episode in adult. Where they suspected bacteremia, two sets from two different sites. Where they suspect endocarditis, we need three sets corrected separately over 24 hours. Then in pediatrics, the volumes are much less, 1 to 2 mils in neonates. Neonates need 1 to 2 mils, and then infants 2 to 3 mils. Next slide. Yeah. Yes, now the other issue about blood cultures is that we obtain, when collecting the blood culture, we should obtain from peripheral venous sites, and we avoid femoral sites because of it's difficult to clean, and then must be corrected by trained staff under aseptic technique. And if other blood samples are needed, we inoculate the bottles first. And then we should observe strict asepsis to avoid contamination. And then there are line cultures and the timing. Line cultures like the central Hickman. We take only if the we take from this only if line infection is suspected, and correct simultaneous with peripheral samples, and then we label corrected. The timing, literature that there was a correction during fever spikes was important, but studies have shown that this one comparing to correction when there are no fever spikes, there was no difference in yield rates of organisms. For best yield, it's usually 30 minutes before onset of fever. That's what studies have shown. Next slide. Next slide. Yeah, transport. After correction of the blood culture, transport to the laboratory should not delay, ideally within less than 4 hours, and then should be dispatched to the reception, should be transported at room temperatures, and the labels should be labeled properly in the patient's presence so that you don't mislabel. Next slide. Yeah, identification of septic focus. In most of the times, for the microorganisms to reach blood, they have to enter through a port of entry. It may be a laboratory should do those investigations that help to identify the source of focus. This is important because some drugs may not penetrate, may be effective in eradicating the microorganisms from the blood, but may not be able to penetrate the site of what? Of infection. Laboratory should also, depending on the presentation of the patient, because the presentation can help to localize and therefore be able to know which particular specimen we need. Laboratory can do analysis of urine or pus or sputum or feces, and at times it may be a biopsy in deep-seated what? Infection, but also can do imaging, a chest radiograph, an abdominal ultrasound, or other imaging, diagnostics as determined by patient's clinical presentation, maybe ACT or a PET ECT scan. In developed countries where we are going, for example, this PET CT scan is very sensitive because it can be able to identify metabolically active foci of infection. Next slide.
That's the end of the presentation.
Thank you very much.
So with that, I want
over to you, moderator.
Thank you so much, Dr. Mutumba, for that presentation. Thank you so much to members. The CPD link is coming in very soon, but I request that if you have any question at this time, please kindly raise up your hand such that we can have that question very quickly. Or you can just unmute and ask your question. But Dr. Herbert Kadama, your question is up. Kindly unmute and then ask that question, Dr. Herbert.
Yes, thank you for that wonderful presentation. Mine is quite a simple one. I just want to know, is there a role of gene expert in diagnosing of sepsis? Thank you.
Thank you very much. As you know, sepsis, the definition is life-threatening organ dysfunction due to a dysregulated immune response to infection. So mycobacteria can be one of the pathogens triggering sepsis. So definitely gene expert has a role in the diagnosis of sepsis.
Can we have another question?
Yes, thank you, the presenter for lab. Yes, I would like to know what is the normal range of lactate.
You want to answer that one before we pick another one?
Maybe, Chair, I'm seeing some questions in the chat directed to me. I could answer them, if that's okay.
Dr. Martin, do you want to pick them on as I prepare the CPD link?
Yes, please. Someone is asking me, Ampigenta is empirical. How is the response according to Septriaxon? I would like to say that the small and sick newborn protocol for newborns still advises ampicillin, and studies have shown that 100 milligrams per kilo is better than 50 milligrams per kg. And that's specifically for the newborns. It is still the first line. If the problem comes in with abuse, people think ampicillin no longer works. Very good for gram positives, and combined with gentamicin, that will work on gram negative.
Yeah, thank you so much, Dr. Mutumba, for that wonderful presentation. It seems our moderator is sleeping, but from the chat, there are some questions that I think you could respond to. Number one, there is the Solomon, who is asking that he has seen majority of the empiric therapy has Ampigenta. So he was wondering whether we could add antifungal or antiviral therapy as we wait for results. Over.
Am I audible? Am I
yes,
audible?
you are audible, please. You're audible, kindly.
Yes,
yeah,
doctor.
because in the middle of that, someone interrupted, and I wondered if I was really audible. So I was responding to the question of someone asking, is ampicillin really sensitive? Yes, it is sensitive, and it is still recommended by the...
So just to briefly answer that, My name is Sepsis Simon, a clinical microbiologist. So largely, when you are approaching sepsis, you have to first of all think bacterial. So you have to first deal with the bacterial causes or the bacterial agents. And so the ampicillin and gentamicin is in good order. Okay? But when that fails, when that regimen fails, okay, you have to only consider antifungals if you think that that regimen, that empirical treatment has covered all the possible scenarios around bacterial agents, causative agents. For example, ampicillin, does it cover all the organisms? Klebsiella pneumoniae, Pseudomonas, and other agents, and all the resistance mechanisms that are involved. So I think at that point, it may be too early, because if you're thinking ESBL as the reason that ampicillin has failed, and then you switch to an antifungal, you might miss that. Okay. So I think the best thing is to, before you switch to an antifungal, first ensure that you've covered all the possible scenarios about around bacterial agents. So you could probably escalate to maybe, if you think ampicillin is not covering agents like Pseudomonas and Klebsiella, you could probably escalate to piperacillin, tazobactam, or ceftazidime, or cefepime, okay? And then if that fails, you could maybe probably now consider, because that's broad spectrum enough, you could now consider switching to an antifungal, because usually fungi are the next thing you think about after thinking of bacterial causes of sepsis.
Okay. Am I audible now? I want to come in on that question. I was
Thank you, Dr.
answering.
Yes, Dr. Immaculate,
Dr. Tatumwa, the moderator,
before we
and
proceed, I want us to...
to...
Yes, thank you. I want us to only proceed up to 2 minutes. So, Dr. Immaculate, you can respond to that, and then we wind up this session. It has surely should. Yes,
Yeah,
Dr. Immaculate.
to emphasize.
Dr. I saw your hand is up. You can go ahead. Dr.
Okay,
Tatumwa
thank you
seems
so
to be engaged.
Thank you so much. I was talking, I wasn't being heard. I wanted to respond to the issue of ampicillin being sensitive. Yes, please, guys, it is still sensitive. It's because we have abused it that it's not working, and we think it's not working. Centers that are still clean and follow the protocol, ampicillin still work. So it is still recommended, and it works very well. So please use it. Unless it fails, go to the second line, or the child has obvious signs of other organisms. The question of gentamicin in asphyxia, it's not an absolute contraindication. In asphyxia, it's advisable that if a baby has got asphyxia, monitor their urine output. It's a very good second line, or rather combination for Klebsiella in babies who have got asphyxia. So if you have doubt, monitor the urine output, and if it's good, give at a low dose of 3 milligrams per kg. I think that's what I wanted to comment. Let's avoid throwing around antibiotics, okay? And don't just add antifungals and antiviral without evidence. Consult, have team discussions before adding these many antibiotics. Otherwise, thank you, and back to you.
So thank you so much, Dr. Immaculate. Thank you, the whole team, for making this presentation. I just hope everyone has learned. It is very important to manage sepsis, mostly, not only in children, but everyone, but mostly in children. It's very important because it has claimed a lot of lives. So for this knowledge that we have gained today, let's use this, let's practice. And as we proceed with this continuation of post-event activities like these webinars, I know we can have very many to tell more people about sepsis. So with that, I want to share these certificates. They've been signed by Professor Peter Waiswa, who is the board chair of PHF, and this one goes to Dr. Irumba. Thank you for the remarkable presentation that you have made today, the 3rd of October, this presentation. And then this goes to Dr. Mirembe. Dr. Mirembe, thank you for being that good pediatrician who has come to make that presentation to us here. And
Thank you.
this one goes to William, and then the one for sister is going to be shared soon. Thank you so much for the presentation. I'm glad that we have been here. Hope enjoy the weekend. Let's meet next Friday.
Thank you very much for hosting us. Good evening.